Okay, is that better? Okay, great. So moving forward. Are we there? All right. Always the AV. There we go. Okay, want to acknowledge funding support for this event. Could not have done this without all of these sources of support and funding. So the School of Medicine Inaugural Impact Symposia Award that we received is most appreciated. Thanks to our Interim Dean, Susan Murin, and Kim Barrett, our Vice Dean for Research, for starting that program. We greatly appreciate it. And my department and the Center for Healthcare Policy and Research were the other two key sources of support. And it's been quite a team effort. This is my planning committee. I don't have time this morning to read all of the names. Those on the expert committee have already met them, but I will just say that this was very much a team effort. And every single person on this list made major contributions to this summit. I want to specifically give a shout out to Dominique Britley and Eleanor McAuliffe, who do really all of the heavy lifting. Dominique was the project manager for this and also made major contributions to the content, and Eleanor did the lion's share of the administrative support. So thank you both, please. I'm going to start with some opening remarks from some of our esteemed leaders at UC Davis. So I'll introduce first David Lubarsky, who's the Vice Chancellor of Human Health Sciences and Chief Executive Officer for UC Davis Health, and then Interim Dean Susan Murin for the School of Medicine. So David, if you could come up and say a few words.
Okay, that's no problem. So first of all, I like not to stand behind the lectern because it's almost as tall as I am. Okay, so welcome, good morning. All I can say is I count my okay, keep me on the straight and narrow, give you really good advice, prevent my A1C from getting into a place where I have to do something about it, and constantly tell them don't drink so much coffee, you may get gastritis with bother so much, right? I know that sounds kind of trite, but it's so true, okay? And they understand it. They understand it. I'm a doctor, and I come to work, and I get up at 6 in the morning, and I start pounding out emails, and I'm drinking coffee. And then I drink coffee all day. Well, that's part of the idea, right? But as someone who has lived experiences that are similar, so they understand it. And so when I think about primary care, I always think about, well, what's the future of primary care? And it's always rooted in people who care about you, who give you advice that's meaningful, someone who understands who you are, what your life is like, and why you do the bad things that you do. I'm sorry, right? Lifestyle changes, right? If we could get to lifestyle changes, there wouldn't be that much need for primary care. Everybody would be healthy. We're not. So reimagine, rethinking primary care starts with the people, right, that are delivering primary care. And it's not really enough to just educate people, but it's really critical to have a workforce that mirrors the community they're trying to serve. It doesn't have to be like, oh, I'm African American, I can treat an African American patient. No, but it's having a core of individuals in practice who understand what their patients might be going through and what the cultural implications are of telling them to stop eating fatty foods, right? Because that may not be where it comes from. And that's not the diet that they're used to. So diversity, equity, and inclusion and belonging are not only alive and well at UC Davis, and thankfully in most of California, but a critical component of delivering care whose advice will be followed, right? So number one is how do we figure that out? And I think we're doing a really, really, really good job in that regard, and really reaching into communities to educate people who return into their communities, because they have lived experiences that make them actually valid advisors. Okay, so that's number one, rethinking how do we get to the workforce that we want. And then number two is, do we really need all doctors, right? And Deborah's there, she knows how I feel about care teams. I mean, we don't, right? We need physicians at the top of a pyramid. But then that care and advice and counseling and coaching is a lot of what sometimes primary care is about, can be directed and delivered by others. So thinking about the care team and really how do we bridge the gap to the areas that are so underserved by being a little bit more expansive in our thinking about how do we get the care and the advice to people who need that and follow. And then the third part of the team, right, without having the right people and having the right pyramid and the right extensions is technology. Right? So people, process, technology. And so I had the privilege, yesterday I was in an all-day think tank, and the national strategy director for Kaiser was there. Fascinating listening to them. The head of Amazon Pharmacy was there. Fascinating listening to them. They're rolling out half the United States next day delivery of medications to your home. And the CEO of Hippocratic AI. I don't know if you guys know about Hippocratic AI, but they're claiming that I tell this person that please don't ever say that again. I'm replacing nurses. I'm like, no, it is a co-op. It is a way I listen because they did a demonstration to actual interviews with a robot. I had no idea it wasn't a human being. They took mispronounced words, misspelled medications, and did a medication reconciliation. Frankly, a lot better than sometimes we do in the hospital. They got it down exactly, and they were infinitely patient and empathetic as they got to the answers that were needed. We're also not always as empathetic and patient as maybe we might be with our patients. But the ability to deploy technology, and then they talked about stuff that I just would never imagine. That, you know, in the database of Kaiser, for example, there's 200,000 people on like anticoagulants. They could call up every single person on the first of every single month at exactly the same time and send out 200,000 calls from a computer so that there's perfect follow-up about and figure out, especially who wasn't coming in for their anticoagulation testing, who was at risk, who was finding extra bleeding. Those were all very algorithmic yes/no questions, right? That robots can do to make us better doctors. It doesn't obviate the need for us to see patients, to coach patients, to talk to patients, but it says this is the one you got to talk to. So rethinking, right? Who we're training, I think we're doing a really good job. Building the pyramid, which can extend beyond advanced practice providers, right? But into community health professionals. And employing technology so that the follow-up is as perfect as humanly and computerized possible, so that the person-to-person interactions, the most valuable commodity that we have, our time, our focus, and our commitment, is directed at the right place, at the right time, to the right patient. So, as we approach, what does primary care look like for the future? How do we get better care? How do we bridge the gaps? How do we no longer have that where you live is more important than anything else in terms of your longevity? Those differences can be erased with the right delivery of care. And just saying we just need more primary care. Yes, we definitely need more primary care. But how do we expand our capabilities given the workforce that we have and the shortages that we know? I'm not even going to start with AI Scribe, which Dad has been working incredibly hard on, but rolling that and getting rid of turning us all into glorified typists and back into doctors, back into the joy of medicine, back into helping people, not figuring out how to type words and click and clap. That's going to change things dramatically, and we can use some of that time we've recovered and a little bit more time with our patients. So technology is not the enemy. Technology is not humanizing. Technology makes us better physicians, makes the community better, makes our patients better. If we control it and use it in the right way, I will then stop and say thank you for the opportunity to talk to you and give you some thoughts for the morning. Dr. Susan Murin, our Dean of the School of Medicine. And I didn't go too far with my document.
Thank you so much, David. I, in contrast, will stand very still in one place. Anyway, thank you so much, Tony, and welcome everyone, and thank you for being here today to share your expertise and to learn together. As a nationally recognized leader in primary care training, the UC Davis School of Medicine is honored to host this summit and to bring everyone together, particularly so many experts in this field. Advancing health equity and access to high quality, culturally competent care is foundational to our school's missions. Now, more than ever, we need to work together to secure a primary care system that meet the needs of our diverse and aging populations in California and nationwide. Primary care, as we know it or have known it, has been under assault for some time. The patient-doctor continuity being disrupted by pop-up healthcare entities in pharmacies and strip malls, et cetera. These things are disruptive and really threaten the primacy of the doctor-patient relationship and can undermine patient-centered care. And as physicians, we know from our experience and from data that great primary care is essential to keeping our communities healthy and improving population health. So forums like this are essential to collectively identifying and ultimately achieving a more robust, effective primary care system in the face of changes, some of which will be good, but that we need to figure out how to best incorporate in ways that serve our patients without, again, disrupting that core of primary care. So one vital outcome of this summit will be the white paper that results from the many expert sessions. The goal is that white paper will not only share best practices from existing state, federal, and other initiatives, but will also identify unanswered questions and a resulting necessary research agenda. So thank you for your partnership in this vital work. I look forward to learning from you today, and most of all, to future collaborations to create meaningful change that improves lives. So enjoy the program.
Thank you both very much. Excellent stuff to think about. Okay, I'm going to give a very brief introduction before we have our first plenary speaker, just to kind of set the stage. I suspect this is something I don't need to tell the people in this room, but just to make sure, because we have a lot of folks who are on Zoom and such. What is primary care? Well, this is the National Academies of Sciences, Engineering, and Medicine's 2021 endorsed definition. It's a long one. Whole person, integrated, accessible, and equitable care delivered by interprofessional teams who are accountable for addressing the majority of an individual's health and wellness needs across settings through sustained relationships with patients, families, and communities. And that whole person health is a focus on overall well-being rather than just absence of disease or treating disease. And it takes into account social influences on health. So that's a high aspirational definition that we're all striving for. And this is just a quicker way to summarize it. Person and family-centered, continuous, comprehensive, equitable, team-based, collaborative, coordinated and integrated, accessible, and high value. It's critically important to the health of America. Many of you may know this already, but we know that from both ecological studies and even individual level patient studies that greater primary care supply and exposure are associated with better health. This is a study I did with Josh Fenton here and one of my other colleagues, Peter Franks, that showed that actually, I take it back, that is not what this one is. This is the ecological study. So this shows that if you have just an increase of 10 primary care physicians per 100,000 in a region, you have a greater life expectancy. And it doesn't matter which of the different models were used. You can see all of them were associated with a positive change in life expectancy. That's in days, but you can see that, you know, this is average, right? So for some people, the average in one of the models was 100 days of extra life with very wide confidence intervals. And that means some people are going to live a lot longer just by being exposed to more primary care. It's also one of the most fair, efficient, and accessible ways for people to enter the healthcare system, regardless of their background. You can see that's I know a busy graphic, but the arrows show you that for family med and internal med, this was a study of visits to different specialties. There's no difference essentially in the likelihood of being seen for Black and white patients. Whereas for many of our specialties, that is not true. There are a couple where it cuts the other way, but not for good reasons. One, for hematology, I presume that's due to sickle cell, but for nephrology, it's because of the much higher rates of renal failure in Black people in the United States, which is related heavily to social influences on health. So the point is, this is an equalizing equity lever. So why do we need this summit if it's so great? Well, the NASM report did designate primary care was good for all these things we're talking about, to the point where it's a common social good that should be viewed as something like clean air and water that everybody has access to and doesn't have to worry about being able to get. But they also warned that the specialty was slowly dying, and that's their term. What are the symptoms of the primary care as the patient? Young clinicians viewing primary care as too much work for too little reward, and therefore we have increasing numbers of patients without a usual source of care as people don't go into the specialty, and those who are in the specialty are retiring or going part-time or moving on to other types of jobs. And that's going to worsen the projected shortfall we already have. And we know that vulnerable populations already live in areas with fewer primary care clinicians, so they're getting a double dose of this. What I ask is this the kind of primary care we really want? And I think the answer is no. There's a lot on this, but I've modified this from a really classic article by Tom Bodenheimer at UCSF. I added a few things. So from the patient's perspective, what's happened is I can't get an appointment. And when I do get in, my visits are short and the doctor is harried and rushed, or the nurse practitioner. Clinicians feel like they're on a hamster wheel, they're burning out. Medical assistants are running around like crazy, not always working at the top of their training. Practice managers say, yeah, it's great to get more patients through because we have fee-for-service payment, but my clinicians are burning out. Health system leaders are feeling this because clinicians are hard to recruit and retain. And then subspecialists, I think this is something we need to emphasize as primary care doctors. Their clinics are full of patients that we could have handled, and that they really are not the kinds of patients they want to be seeing. I picture surgeons not wanting to see stuff that is really not going to be a surgical type of issue. So I don't think this is what we want. It's bad for everyone in health. I think this is also really a burning platform issue that the public needs to be aware of. Our healthcare system severely underperforms on key health indicators next to other industrialized nations. We spend way more. This graph shows we're that curve at the top, more than double in terms of a percent of our GDP on healthcare than any other OECD nation. These are comparable industrialized nations. And yet we have worse health outcomes, which I'll show you in a second here. Just by one example, we're the bottom curve here. This is life expectancy in the United States. And you can see that we've been falling behind for some time. That dip is COVID, which basically we were completely ill-prepared to deal with in the United States. And it's partly because of a bad primary care base, but also our public health base. And we're starting to rebound a little bit. But I think this would shock most people in the United States because we kind of tout ourselves as having the best healthcare in the world. And if you can get it, we do. But it's not always the case for everybody. And this also hides that the life expectancy is much shorter for people of color in the United States, orders of magnitude 5 to 8 years or more. And this just shows, again, maternal mortality in the US. That's not something to be proud of. You know, double the rate, more than double the rate of the industrialized nation's average. And, you know, again, sort of what's happening here, you can see this is among those economically well-developed countries. We're at the bottom for adults that are likely to have a long-standing relationship with a primary care provider. So what's causing the signs and symptoms? I would agree that it's not only underinvestment, but that is a huge problem. So 35% of all visits in the US are primary care. It influences up to 90% of costs, right? Because we start the process, we refer, we do all these other things that get the chain going. And we get about 5% of healthcare spending, maybe a little bit more depending on which models you look at. People in the room are probably, some of the folks that are experts on primary care spending are saying, wait a minute, you know, how do you get 5%? It varies depending on the model, but it's way less than other elements of the healthcare system, such as specialty care and hospital care. So I think we can diagnose that chronic and severe underinvestment is one of the factors that's crippling primary care, and it's worsening health in our country. We don't just need more, but that's definitely part of the issue. I'm going to skip that in the interest of time. So we do have promising treatment. We know this was a really interesting observational study in California that looked at among private payers and provider organizations. Greater investment in primary care was associated with better quality, fewer hospital visits, and for the provider organizations, lower total cost of care. Such that if those provider organizations in the lowest brackets spent as much in the highest, would have saved a whole bunch of hospital stays and ED visits and about $2.4 billion in healthcare spending. So this is huge. And it is observational, it's not experimental, but at the same time, it's very suggestive. The average primary care spend, again, was only around 7.5%. As you'll see, there's different ways you can define that, so it's tricky. So I would say the prognosis is still guarded, but it's looking better. I do think because of all these things that I've mentioned, we're entering a policy window. This is John Kingdon had this policy window model where political imperative, effective policy or intervention, and a perceived problem all line up. Often policy windows open only for a very short period of time. And I do think we're at that point. As Winston Churchill said, you can always count on Americans to do the right thing after they've tried everything else. And I think we have tried everything else, managed care, the patient-centered medical home, ACOs, they've all had some impact, but ultimately my sense is we're rearranging the deck chairs on the Titanic. There's got to be a sea change in how we approach this. There's a lot of state level efforts now happening. You'll hear about the Office of Healthcare Affordability's new primary care investment benchmark recommendations tomorrow. These are states that have sort of beat California into the punch, but we're getting there quickly with the state level efforts to reinvest in primary care. And there's federal actions such as the bipartisan White House and Cassidy bill or act, the PCPs Act, that would do several different things to push Medicare, CMS to help with the primary care crisis, including with the workforce aspects, improve adequacy of pay for primary care clinicians in Medicare. It isn't, I agree fully with what David said, it isn't going to just be about money. We have to also change the way that we provide the reimbursement or the support to primary care. We're heavily towards the left side of that fee for service. It's really tricky and I think non-sustainable for primary care in the long term. We have to come up with ways to pay for the types of teams and relationship-centered care that he referred to. The purple is the core team that we have traditionally thought about with family medicine and pediatrics and general internal med. The blue, though, is the extended healthcare team that we now need, and that unfortunately our current reimbursement model doesn't really help us support. Social workers, behavioralists, pharmacists, et cetera. And then there's even more in the community: home health, social support services, people to help us identify and intervene on social influences on health. The dollars per work review doesn't really address that, unfortunately, so it's tricky for us. So what are we seeking to accomplish here? We're seeking to figure out how do we move forward. Number one, convey that this is a burning platform issue for health in the United States and the viability of our economy. Convene an esteemed and accomplished group with national representation to leverage this momentum around revitalizing primary care that we're starting to see at the state and federal level. And as Susan identified, really, we're going to share best practices, but really we want to identify what do we not know and how do we need to address and answer those unanswered questions as quickly as possible so we can revitalize our specialty, which primary care is. I'm going to skip this other than to say the expert committee is fantastic. We had an amazing kickoff session last night where a lot of good ideas were generated. I believe you should have packets that show the people that are in the expert committee. So I just want to make sure that you take a look at their bios. This is a lifelong type of dream situation for me to be in with these folks here. And we're going to produce that summary white paper, as I mentioned. I'm going to skip these last two because you have the agenda for today in your packets. We'll have a couple plenaries and then a poster session. So I'm going to move directly now to introducing our first plenary speaker. I think we're pretty much on time, so that's good. This is Dr. Alana Yurkowitz. She is going to set the stage for us. She's a primary care physician on the faculty at Stanford who has a fellowship training and board certification in internal med and oncology and hematology. She co-directs the largest primary care residency clinic at Stanford and is also co-director of their innovative Primary Care for Cancer Survivorship Program, which provides primary care, as you might imagine, for patients either with or who have survived cancer. Now, Alana's work is highly relevant to our discussions today. She wrote the book Fragmented, among other things. It's a doctor's quest to piece together American healthcare, which I would highly recommend. It identifies root causes of the US healthcare system's failings. And through her insights and experiences, she's going to lay the foundation for our discussions over the next couple of days about how we find our way out. So let me please introduce and welcome with me Dr. Alana Yurkowitz. So you can
Thank you so much for that introduction. I want to thank the whole organizing committee, Tony for inviting me, Rich, Dominique, and everyone else. I'm really looking forward to a productive conversation over the next 2 days, and I'm really honored to give the first plenary session to you. So I'm going to be talking about my thesis, which is that primary care, the main reason that we're in crisis is that it is fragmented. And I wrote this book on it, and I'll explain a lot more what I mean by that. So first, I'd like to take you through a real patient case and then make my case for why the root cause of why primary care is in crisis. I don't think it's a secret to anyone in this audience, as we just heard, that primary care is in crisis, despite many of the people in this room loving their work as I do. And I believe it is fragmented into transactions, and there's 3 main reasons why it's fragmented. They're easy to remember because they all start with the letter T, and we'll go through all of them: tech, team, and time. And then I want to go through 2 examples of the ideal. What is the opposite of a fragmented primary care system? A relationship-based clinic, and we'll go through 2 examples of that. So first, let's start with a real patient case. So I call this patient Devin, changed just a few details to protect his confidentiality, but this is a real case. So 36-year-old with a history of congenital kidney disease. He came to our primary care clinic, moved to California from out of state, and he came in to establish as a new patient. So I'll take you through the nitty-gritty. He comes in for that first visit. He has a 30-minute appointment. We're actually pretty fortunate at Stanford for new patients to have 30-minute appointments. In many places, those appointment slots are much shorter. That 30 minutes, however, encompasses everything. So he arrived right on time, but it took 10 minutes for the medical assistant to get him into the room, get him into a gown, fill out medical history forms, get his vital signs. And then the primary care doctor comes into the room, clicks through Epic, notices there's no medical records in the computer because this patient came from out of state with a different not shared health record system. But fortunately, this was a very diligent patient. He brought a stack of papers to go through with his PCP in those 20 minutes. So the primary care doctor decides, well, this is 300, 400 pages of outside records. Let's just go through the highlights, but I'm going to get a baseline set of blood tests on you today. So she orders a baseline, and it comes back after hours that day with a hemoglobin of 10.1. So the patient is anemic. So she looks through those 300, 400 pages of outside records, trying to find the needle in the haystack. Has this patient had a CBC done recently? Have they been anemic before? In the 300 pages, couldn't find a previous CBC. So she is a very diligent primary care doctor. So she messaged the patient on her own time after hours. And then per this brief message exchange, patient wasn't sure if he had anemia before, but fortunately, he said that he had no symptoms. There were no signs of active bleeding. And another fortunate thing was he already had an upcoming appointment in the books with a kidney doctor, with a nephrologist, who was a second set of eyes to review the anemia and started the patient on a medication, an ESA, to stimulate the red blood cells. And so at the time, neither the primary doctor or the kidney doctor pursued additional workup for the anemia. Shortly thereafter, the primary care doctor gets a notification in the computer system that the patient is in the hospital because he had passed out at home. So he is in the hospital. They take his vital signs. His blood pressure is critically low. They gave him a lot of IV fluids, though. He had lightheadedness that improved. They did note when he came in that he had anemia, and it was a little bit worse than the previous reading. It was now 9.4 from 10.1. But in the hospital, they said that's not a reason to keep this patient in the hospital. Send this off to the primary care doctor, the nephrologist, for further workup. And the primary care doctor saw it, placed an outpatient referral to gastroenterology, and wrote consider a colonoscopy. So primary care doctor, gets the notification, her patient is in the hospital, gets another notification, automatic, you need to set up a post-hospitalization follow-up, which was the correct thing to do. So she messages her medical assistant to set that appointment up within 1 week. The medical assistant sends a message to the patient, but unfortunately that doctor is very busy and had no appointments for 1 month. So medical assistant offers the patient a choice. You can come in, see any one of our other wonderful providers, or wait 1 month. Patient decides, well, I just moved. I went through all my history. I met this person once. I don't want to meet another person. I really liked her, so chose to wait that 1 month. And did get the notification that his doctor had ordered a colonoscopy, but one button had been clicked mistakenly. It was ordered as a screening instead of a diagnostic, and his insurance told him that it would cost $3,000 out of pocket. And he said, I'm just going to wait to talk to my primary care. Is this really something that I need? So he unfortunately did not make that next appointment. The primary care doctor gets a notification. He was hospitalized a second time. This time his heart rate was high. He was tachycardic. He had passed out again. Blood tests in the emergency room showed even worsening of an anemia that was not responsive to the medications, as well as new elevations in his liver enzymes. And very unfortunately, a CT scan was done. That was the correct thing to do, but very unfortunately, the reason for this patient's anemia was a primary colon cancer that was causing bleeding through his stool. That was occult that he could not see with the naked eye. And by the time he came in, it had already spread to the liver. So this was a stage 4 colon cancer. And so I actually went over this case with Tony before coming here, and he said, this is every primary care doctor's worst nightmare. And I agreed with that. You know, I think this was a story of a perfect storm of many external factors that led to kind of that top bubble. This was a good primary care doctor who was set up to fail. And you'll notice for all the reasons that this case went wrong, none of the reasons were that the primary care doctor lacked diligence or lacked caring. So it was a perfect storm. What was wrong in this case? There were unshared medical records when the patient came in from out of state. There were disorganized medical records, 300 pages of records, and she couldn't find the one value that she was looking for. There was a long wait to see her, 1 month. I realized maybe in this room, this is actually a short wait, but 1 month was long enough for this perhaps to progress from a treatable colon cancer to a metastatic colon cancer. Insurance barriers. The first visit was too short. There was no time for any of that follow-up in between. And then there were many doctors in the hospital and outside starting from scratch when seeing this patient's case. So what is the opposite? What is the ideal? You know, what should the primary care doctor have been able to do in this case? So a few bullet points that I don't think will be, you know, too revelational to anyone in this room, but the primary care doctor should be the quarterback of your overall health, because health is a story. It changes over time. So ideally, the primary care doctor is your first point of contact, someone who knows you, can react to changes, put them in context and act accordingly. And in order to do that, it sounds so simple, but it is worth saying it requires continuity. The primary care doctor needs access to communication and seeing their patients, as well as access to data for her patients. And so I wrote this book, Fragmented, making the case that the root cause of what is wrong with primary care, and actually just healthcare in general, is that doctors are working in this constant state. Doctors and other healthcare providers, I should say, are working in this constant state of being partially blindfolded to the full details of a patient's case. And that leads to medical errors and so many other problems that are at the root cause of why primary care is in crisis. So let's start with the first T, tech. So in 2009, if anyone was in practice before 2009, you will remember that you used to chart before electronic medical records. And you can see some photos down here. I don't know if anyone can read the prescription on the left. I certainly can't. And you would have to walk into these big rooms of filing cabinets just to get access to a patient's records. So in 2009, paper records were converted to electronic medical charts through legislation from Congress called the HITECH Act. And this was a major step up. You know, I don't think anyone wants to go back to these handwritten illegible notes that were lost in filing cabinets. And with the tech, there was the potential to connect large amounts of patient data seamlessly. That was the promise of the electronic medical records. However, that promise has not been lived up to. And one of those reasons is vanishing records from one site to another. So maybe by a show of hands, who in this room has used a fax machine in their practice? It's pretty much everybody. And maybe another show of hands, who learned to use a fax machine in medicine? Maybe you've never even used a fax machine before. I'm showing my age here. So 90% of healthcare facilities use faxes, and the graph on the right is from the ONC, the Department of Health and Human Services, that's been looking at how many healthcare organizations do what's called interoperability, which is 4 components: send, receive, find, and integrate outside health information. And while that number has been going up since 2018, it was 46% in 2018. It's 70% as of 2023. Well, it's still 70%, which means 30% of healthcare organizations don't share records at all, such as the case of Devon. Now, there's another problem with EMRs, which is that even within one system, there was all this data, right? Big data, but big data is big. So if you have big data with lack of organization, you have a chart that's maybe greater than 10,000 words. So if I had gone back to Devon's old healthcare organization, I clicked through his chart, it would have been 10,000 words. It would have been longer than Bleak House by Charles Dickens. And unlike Bleak House, though, it would have been ripped up. The analogy here is that doctors have to click through all of these discrete tabs because the EMRs are not written like a book. There's no clear beginning, middle, and end. It's like Bleak House, but with all the pages ripped up out of order. Maybe some of them are repeated, and they're scattered in dozens of different disparate tabs. There was a study that showed actually 60% of words in EMRs are repeated from one note to the next. And then there's some other relevant numbers here, right? So that primary care doctor had 1,000 plus other patients, was doing 15 plus visits per day, tending to 50 messages and notifications, which left 0 hours to sift through and put together a broken up Bleak House. So maybe by another show of hands, who recognizes what I'm showing on this slide? So this is Epic, of course, the biggest electronic health vendor, responsible for more than 50% of shares. And, you know, I've given versions of this talk to non-primary care doctors, and it kind of looks like I just don't know how to organize my slides. I mean, where do I even look? This is so messy. And there's a reason for that, because this is what primary care doctors are actually dealing with every day. So most electronic health vendors, even Epic, the biggest one, have data that is disorganized within one health system. So you have maybe on the top of your screen 24 tabs. You have on the left side of your screen another 24 tabs. You click every one, it expands like Russian dolls. And it takes a lot of time and effort just to find the one piece of information that you're looking for. And I'm going to talk a little bit about the fallout of that. And it's not just in retrieving data, it's also inputting data that is manual, onerous, and clerical. This is an example of, let's say the emergency room doctor wanted to order that CT scan of Devon, and they type in CT abdomen, and this is what comes up. It's this whole litany of things, and many primary care doctors and others could inadvertently just choose the wrong thing because it's so messy. And this was shown by a really nice paper a couple of years ago that looked at how many clicks it took to order a simple over-the-counter medication, Tylenol. So they looked at 4 different healthcare sites, and the range was 14 to 62 clicks. And you'll note in the bottom here that that number of clicks led to an error rate of 30% at one of the healthcare sites because people were just confused about what to click and how to prescribe Tylenol. This was another paper that looked at how many clicks it took to get through a 10-hour shift in the emergency room. That number was 4,000. And you can see on the right how those emergency doctors then spent their time. 44% was spent on data entry, 12% was spent on review, which left 28% of their time for patient contact and 13% of their time for discussion. So what is the fallout of this fragmented technology? Well, this was the same technology that was intended to reduce doctors' workload by gluing patient data together. It has done the opposite, unfortunately. It has drastically increased it. So this was a paper from JAMA last year that showed that primary care doctors, for every 8-hour day seeing patients, that generated 5+ hours of EMR work. So primary care doctors were either squeezing this in during the day or taking it home with them at night, leading to burnout, of course. In addition to burnout, this also leads to errors and near misses. This was a very frightening paper that looked at medical malpractice claims, and it went through 248 cases that involve the EMR. And some of those cases were very terrifying, I think, in their familiarity, because it was something that could happen to everyone. Similar to Devin's case, there was a case that was reported of a primary care doctor missing a cancerous result on a pap smear just because that had been routed to a tab that was different from what the primary care doctor expected. So by the time the primary care doctor saw it, it was a year later. And a separate paper surveyed primary care doctors and asked, how likely is it that they can miss abnormal findings as a result of the EMR? And greater than 50% said that it was likely to miss abnormal findings. And then 30% said that they had personally missed abnormal findings thanks to the EMRs. So that's fragmented tech. Let's move on to part 2, fragmented teams. So this is a little bit tongue-in-cheek, and I do apologize. It's anachronistic for the guy when half of primary care doctors are women. But the foot guy sent you here. This is a cartoon from the New Yorker. I'm strictly a knee and upper shin guy. You're going to have to see a lower shin, upper ankle guy. How subspecialized we have become in medicine. So who looks for the big picture? Going back to Devin. So his kidney doctor, had an eye on his anemia, but said the anemia was from his chronic kidney disease. That was that lens that she approached the patient case. In the hospital, the emergency room doctors and the inpatient doctors said this patient has anemia, but it is not an inpatient issue. And then later, once the patient was actually diagnosed and treated for colon cancer, still actually had anemia, but the oncologist's job was to treat the colon cancer. It is the primary care doctor's job, of course, to look for that bigger picture. That is why primary care doctors are so critical and the crux of what is good medicine. But in order to look for that big picture, primary care doctors need to be, I don't love this phrase, working at the top of their license. But there's a reason for that phrase, because the daily work of a primary care doctor requires so many tasks that doctors don't necessarily have to do. So EMR legwork, for example, sending some patient messages, insurance paperwork. This was a paper that came out that showed that if primary care doctors did everything they were tasked to do in a day, we would all be working 26.7-hour days. So of course, it's really critical to get that work to the right level of care so that primary care doctors could do what only they can do, which is look for that big picture in a patient story. It's about 2/3 in this current landscape with EMRs, 2/3 of primary care doctors' work doesn't actually need to be done by an MD. And currently in most practices, the primary care doctor is doing everything at once. They're functioning as the doctor, the nurse, the social worker, the dietitian, the pharmacist, and the medical assistant all wrapped into one. I would argue because of lack of funding. And this is called team-based care, of course, and team-based delegation lags in primary care where I would argue it is needed most. So let's say Devin goes in to see his oncologist. What does he get when he goes to see his oncologist? He gets a team. He gets a medical assistant that has scheduled that appointment. He gets a scribe that comes in with the oncologist, writes notes, searches the EMR. He gets a nurse that triages and answers some straightforward questions that he might be having, deals with all the insurance and the prior auths and all of that paperwork just to get him care. He also gets nurse practitioners and physician assistants who are a crucial part of that team and see him for symptom follow-up. Now, what does he get when he comes to primary care? Maybe he'll get a medical assistant that he doesn't have a continuous relationship with because that person is shared among multiple doctors, as well as minimal other support staff. And the graph on the left just shows how much time that primary care doctors spend on EHR activities compared to other specialties. And you can just see compared to surgeons, they're spending they get twice as many staff messages, 5 times as many patient messages, and 15 times as many prescription messages, and they lack the support staff to handle it all. So that same paper that showed that primary care doctors squeezed 26.7 hours of work into a day modeled what that would look like if primary care doctors had the same team that an oncologist has. And that number went down to 9.3 hours with team-based care. So you can say that's still greater than an 8-hour workday, sure, but it is shorter than a full day, and it is a great improvement from the current status quo. And then finally, I want to talk about the third T, fragmented time. So a very 30,000-foot view. This whole summit is dedicated to optimizing the primary care spend, but let's just talk about how most primary care is funded in the US. So 88% of medical facilities still operate fundamentally according to a fee-for-service schedule. So what is a service? Let's say you're in oncology, that's a round of chemotherapy, or in orthopedics, that's a joint injection. In primary care, what is a service? A service is the office visit. It is the face-to-face, before COVID, it was face-to-face, but it was the face-to-face visit with the patient. Meaning follow-up is financially disincentivized. So what is compensated? The office visit. What does that mean about all the other work? Well, that's generally uncompensated. What does that include? It includes sending patient messages like, hey, Devin, I noticed you were anemic. You know, is this a new finding for you? Are you noticing any blood in your stool? It involves reviewing test results, ordering new tests, conferring with other doctors and team members, as well as reading medical charts and writing notes. Typically, all of that work in primary care is uncompensated work. The other relevant factor is that follow-up appointments are generally reimbursed less than the one and done in medicine, the transaction in medicine. So this is a busy slide. We don't need to go through the numbers. It's all to make the case and to show that for Medicare reimbursement, when you see a new patient visit for any level of complexity compared to an established patient visit, that new patient visit reimburses higher. And, you know, you can say this is recognition for the cognitive horsepower that it takes to see a new patient. But the result is that it disincentivizes the follow-up that is so important in primary care. So let's just talk about that follow-up. Primary care fragmented into these brief transactions, right? So let's put together those two facts on the previous slides. The financial incentives are stacked to see, number one, more new patients, and number two, in face-to-face visits. What are you going to get? A typical primary care doctor's panel is going to swell to over 2,000 patients to kind of earn their keep. And then their 8 a.m. to 5 p.m. is filled with those visits, meaning visits are going to get shorter to accommodate. All of that other uncompensated work spills into off hours. Primary care doctors do all of this work at nights, on weekends, on their own time. And then literally competing with 2,000 other patients, every patient is going to struggle to access that doctor who knows them. The wait lists are growing. These numbers are growing in the wrong direction nationwide. The average time to see a new primary doctor is 26 days. It's getting longer, and follow-ups are even worse than that. So desperate to connect with their primary doctor, patients are trying to connect in other ways, such as sending messages. But in our fee-for-service system, that's just yet another uncompensated channel. So now practices are saying, hold on, we're trying to dissuade that by tacking on, there are places that are charging patients to send messages. So what do patients do? They often hoard a year's worth of problems for these coveted visits with their primary doctor. And I put this up here because I practice at Stanford. I'm also a patient at Stanford. And just for fun, recently, I tried to make an appointment with myself, and I was unable to. I could not see myself in the next 3 months, but I like to continue searching for someone else. So what happens? I think we have lose-lose options right now. So what is the primary care doctor's perspective? They have a few choices in this system. Everyone in this room has probably done, you know, a lot of these things. You overbook appointments. You take hours of work home with you on nights and weekends just to squeeze that 27 hours of work into a day. You go part-time because everybody knows the secret, which is that part-time in primary care is full-time. Or you burn out, and there's a crisis of burnout. People are leaving primary care entirely, even when they love primary care. They love taking care of patients. And then, of course, fewer medical students on the other end are entering primary care. They're flocking towards specialties. And then what's going on from the patient's point of view? Well, they can't get appointments, right? So their choices, they self-manage medical issues. They turn to Dr. Google, or they turn to urgent care or the emergency room for not emergency issues. Or they decide to message their doctor, and either they get a response from someone else, they get a bill, or they don't get a response at all. Or they just go in to see someone. They just want an appointment, so they see anybody rather than their regular doctor, and they're starting from scratch every single time. So let's go back to the ideal. What is the opposite of these fragmented transactions? The opposite of fragmented transactions is continuity. And in continuity, that is relationship based. It is a doctor who knows their patients and patients who know their doctor and can get in or communicate with their doctor in other ways and don't have to reinvent the wheel every single time. So we want to get rid of all the stuff on the left. We want to get all the stuff on the right. We want doctors who know their patients, appointments. We want work to get to the right level of care. So there is another way. And I know we're going to be spending 2 days thinking creatively about how to fund these other ways. So I want to go through 2 examples of successful primary care clinics that are not dealing with the current crisis in a way. So this example is Stanford Coordinated Care. I wrote a chapter on it in my book because I shadowed with them for a while, and they were it was like being in a different world compared to primary care that I was used to. So they started by saying that fee-for-service is essentially a non-starter in order to open up the clinic the way they wanted to. They looked at the highest spenders, and it was 5% of patients that accounted for 50% of healthcare costs on Stanford's employment plan. And so they asked for a lump sum from the insurance company upfront. This was limited to Stanford employees and their family members. And they looked at how much they were charging the insurance plan. It was about $48,000 per year. And they did the math and they divided up that number with how many providers they could hire. And with that initial lump sum, they used it to invest in a team. So they hired a physical therapist, a nurse, a social worker, a pharmacist, a dietitian, 4 care coordinators who were medical assistants by training and then had another month of training to do some more work, as well as 2 doctors. And amazingly, they were also all co-located in the same location. So this was true team-based care where they sat next to each other and could talk to each other every day about their patients. And so the care coordinators, they did a lot more than what medical assistants are typically trained to do. And again, it only took 1 month of training. They were trained to do a lot of those EMR tech tasks as well as admin tasks. And so without fee for service, this practice capped at several hundred patients instead of several thousand patients. It was about 200 to 300 patients instead of 2,000 patients. And as a result, doctors had the time. All 3 T's were addressed here. They had the time for 2 hours on new patient visits. Can you imagine that? How luxurious. And 1-hour appointments for follow-ups. The medical assistant or care coordinator would come in every visit, and they would be the ones typing and placing orders so that the doctor could be face-to-face with the patient. And then I just wanted to talk about my clinic briefly, because we did something pretty unique at Stanford, and I'm very grateful for all the support that we have because it was kind of a wild idea. I think I was the only person who completed a Hem/Onc fellowship and then said, I want to take a job in primary care in our program's history, and it was met with great consternation at the time. But there is a reason for that, and the reason is this quote from a cancer patient and survivor on the left. The lack of guidelines and providers who understand the very long-term needs of cancer survivors is an unmet need. I have not found a provider who understands both sides of my current needs. Internists typically do not understand my cancer, and oncologists do not understand my non-cancer health maintenance needs, such as monitoring cholesterol and blood pressure. And so patients are typically ping-pong back and forth between oncology and primary care once they finish treatment. And what we did was we opened a clinic that was primary care for cancer patients and cancer survivors to eradicate one of those T's, the team. So it was all co-located in one place. And it was modeled essentially after geriatrics, which is primary care for just a specialty population. It is primary care for people over 65. This was primary care for patients with cancer. So patients were not ping-pong back and forth between the different teams. And finally, I just want to say, there are a lot of non-solutions that I think people propose to. Everyone knows primary care is in crisis. I think everyone now is even learning the language that it's in crisis because it's fragmented. And people are coming up with solutions. And I would say if it is not addressing a root cause, and that's why they all start with the letter T, they're so easy to remember, of tech, team, or time, it often becomes a non-solution where the solution that is offered to primary care doctors is a solution of just do it. It is just squeeze it in anyway. And I'll give an example of this. I think I can pick on New York because we're in California. So New York City Health and Hospitals, this was a piece that came out recently by Political Pro. They were slashing appointment times for new patients from 40 minutes to 20 minutes. And I think the relevant thing here is that this was touted by many as a solution. This was great. Like now that 20-minute appointments exist, we're solving the access problem. New patients can come in. Well, of course, that's only exacerbating every single one of those mismatches we just went through. It's going to lead to probably a burned out primary care doctor who's going to end up seeing 0 patients and make every access issue worse. So finally, just going back to Devin, I ended up taking him after he was diagnosed as one of my patients in the cancer survivorship clinic. So we did have some continuity, right? His cancer history and all of his other internal medicine issues were addressed in one place. However, I will say we were still within a typical healthcare organization where a lot of workarounds needed to be created in order to cultivate continuity. So things that I did with him, I scheduled monthly visits in advance. I told him to advocate for himself when he sends a message to write, please send directly to Dr. Y to make sure that it got to me. I overrode same-day appointment slots frequently to see him. I often called at lunch or after hours. And I would say everyone in this room has done things like that, but the onus, of course, is on systemic change, not on individual primary care doctors and patients to advocate for themselves. And so finally, if you're interested in learning way more, I wrote this whole book, and I'm looking forward to talking about solutions over the next 2 days. Go to fragmentedmedicine.com, and I'm happy to talk individually to people as well. I brought 4 copies. That was all I could carry, and thank you so much for your attention and time today.
And we have time for about 15 minutes, right, of questions. We're going to alternate them, right? So if we can.
Yeah, start with the live.
So if you can start with one from the live audience and then I'll feed one from the Zoom.
Sure.
And if you can repeat the
Yes.
question.
Okay.
Any questions for everybody? Who wants to think about?
Yes. I think in the back was the first question.
Hi, Alana. Thank you very much for the talk. If I understood you correctly, this special clinic for Stanford employees, provides a full range of services and seems to have solved a lot of the problems that we're confronting. But the number of patients that are actually seen is pretty limited. It seems that there are other solutions, some of them controversial, like direct primary care and even concierge care, that are following similar models that provide a lot. They generate a lot of patient and physician satisfaction, apparently, but it doesn't square easily with the need to address population health and access more generally. So,
Right.
how have you been thinking about that there?
Right. So the question, just to repeat it, was about the clinic Stanford coordinated care, and if that reduces the number of patients that are seen overall, kind of how does that square with health equity and access? And you had also brought up direct primary care and concierge medicine, which is an analogous model that just asks for that lump sum up front, but the lump sum is coming from patients' pockets instead of course coming from the insurance. And anyone who's seen or worked in concierge or direct primary care knows the audience that type of practice attracts. It is good for a certain subset of the patient population, but it's a subset of the patient population that can spend $150 a year, or in the Bay Area, often a lot more than that, in order to access their doctor. So if you're seeing only 200 or 300 patients, every single one of those 200 to 300 patients is, of course, getting better care. But then what about those, let's say, 1,800 other patients that otherwise would not be seen? Well, it's a great question. And those patients are going to be seeking care elsewhere. And I think the problem that we have here is that this model of Stanford coordinated care is so sparse. It is a model that doesn't exist in most parts of healthcare organizations because fee-for-service is still the dominant payment model. And if we generalize that model more to the Stanford coordinated care model, and you have doctors that are seeing 200 to 300 patients, Well, I think someone gave an example yesterday of only seeing their primary care doctor twice within 10 years. There are many patients like that that actually don't need that frequent appointments. And so I think, if you balance it out with the patients thinking about 60% of patients have one or more chronic illnesses, the rest of those patients do not. Do you need to see your primary care doctor that often? Is capping at 200 to 300 patients a sustainable model? I think it is. And I've talked to economists who have gone through the numbers, I think in a lot more detail with me about how if this model was kind of extrapolated and it encompasses not just those kinds of patients that were being seen in Stanford coordinated care, the really complex ones, but also patients that maybe come in for an annual every 1 year, every 2 years, they will have access because they don't need to see their primary care doctor that frequently. Thank you.
Thanks for a terrific talk. I'm Russ Phillips from the Harvard Center for Primary Care. And I think I agree with you completely about moving to hybrid payment, but I also think that we need to think about what we need to really provide the services that primary care is meant to deliver. The case of Devin really is a case in some ways of coordination of care, where I'm not sure Devin needed another visit. He really needed somebody to bring him in for the laboratory workup for anemia, and then potentially to help organize and make sure he got his colonoscopy properly. And I should say my system, I have nobody to help me do that. And if I were to refer a patient for an urgent colonoscopy, it's still to take 6 months unless I personally call a GI specialist to try to beg and get them to be seen now. We have patients in our practice with rectal bleeding, and we can't get any help from the hospital in providing the coordination of care, while at the same time we're building a $1.5 billion cancer hospital to take care of patients like Devin who develop metastatic colon cancer, and which makes no sense. But I don't think we can count on our systems to really be helping us. So we really need to think about how we can support primary care to reduce fragmentation, actually, even within our own systems of care.
I completely agree with everything you said. And the question was about Devin and it being really a care coordination issue. I guess the one thing I might disagree with you on is, did this patient need a follow-up visit really to talk about the next steps? The primary care doctor in this case did order the colonoscopy, and she made a mistake. She ordered it as screening instead of diagnostic, but had she ordered it correctly, let's say it's diagnostic, insurance had covered it. He did get a call, let's say, from gastroenterology, and there was an appointment that was available. He still didn't go forward with, he still might not, I would say, have gone forward with the colonoscopy because it was a conversation that he was seeking with a doctor who knew him to say, did he really need this? Was it necessary? I mean, every test or procedure comes with some risks. And I don't know actually if he would have gone through with the colonoscopy had he not had that conversation with someone that he trusted. So I do think, it was a question of care coordination for sure, but it was also still fundamentally an access issue. Because I think he needed that appointment with the doctor that he trusted to go forward. But yes, care coordination, GI is dealing with the same T's that primary care is dealing with, subspecialties are dealing with too. So that is why you're in those lose-lose scenarios for gastroenterology too, and patients are waiting 6 months to get an appointment. So I think everything we talk about from a primary care standpoint, we can certainly extrapolate thinking about funding models for other specialties too, to reduce wait times.
I have a question.
Yeah.
I'll project, you can repeat for me.
Sure.
So just talking about the Stanford Clinic and the 200 to 300 patient panel, and then replicating that model. But there's a question also about workforce, right? And training and finding enough primary care docs to actually start to replicate that model. So I'm curious if you have any comments about the workforce.
Yeah. Well, I think one really relevant piece of this clinic was the care coordinators who I mentioned. Oh, I apologize. It was about the workforce required for a model like Stanford coordinated care and whether that can be generalized. And so I was saying that I think one of the really relevant and unique parts of that clinic was the care coordination role, which is a role that primary care clinics often don't have. And so these were trained medical assistants. And again, the relevant part was that it only took 1 extra month of training to get them able to do all of this stuff that typically primary care doctors are now doing themselves, doing things like scouring the electronic medical charts, pre-charting notes, so they were kind of functioning as scribes, pending orders, and then dealing with the back end, the insurance paperwork, writing letters of appeal and things like that that the primary care doctor can sign, where typically medical assistants, their job is to take vital signs, get patients into a clean gown, and maybe that's it. And so I think there is a lot of workforce that's available because it took so little training just to get to that level of team-based care that we were seeking, that freed up then the provider's time to spend time with their patients. And the other thing about that clinic was it was just 2 doctors in the initial clinic for those 200 to 300 patients. And in terms of recruiting and retaining, their satisfaction was so high. I mean, I shadowed in this clinic mainly for the book, and I was like, maybe can I take a job here? Are you hiring when you're done? I mean, I think this is the kind of clinic that everybody would love to join because it lets primary care doctors do what they're trained to do, which is spend time with their patients. Yes, thank you.
Hi, buried in this fantastic presentation is that there's a health insurance company that wanted to charge a patient $3,000 for a screening colonoscopy.
Yeah.
And I think it begs the question, do health insurance not belong with primary care? Insurance is to protect for unexpected and catastrophic outcomes. Primary care is neither unexpected nor catastrophic. And maybe what we need to think about is divorcing health insurance from primary care and delivering it as a public good in the way that the NACE report recommended.
I love that question. So just to repeat the question, it was referencing the $3,000+ colonoscopy for Devin and whether there is a role of divorcing health insurance period from primary care. I don't pretend to have an answer, to that. Direct primary care is a good model, I think, to look at here, where they do divorce from insurance companies completely and have had a lot more success getting things like all of the screening, like colonoscopies, mammograms, pap smears, vaccines, A1Cs, lipid panels, all of that stuff that we know is the bread and butter of primary care. Is there a role for having more models like that? But the funding would have to come from somewhere, and direct primary care, again, it's coming from patients' pockets. So who is going to fund a model that completely divorces insurance from routine preventative care? I don't know the answer to that.
The insurance companies can still fund it, they just can't administer it.
The comment was insurance companies can fund it, but they can't administer it. I think it's good food for thought, and I think we should talk about that during our breakout sessions. Thank you. I think there's one in the back.
Hey there, my name is Kelly Babria. I work for a state Medicaid program now, but I spent a lot of my career on the healthcare delivery side and the safety net in California. I think the model you presented, actually friends of mine worked on that model at Stanford, is really an amazing proof of concept of what can happen, like if you invest in primary care and if you redesign it. And we have pockets of those models that we've seen even across Medicaid in California. And I think I spent a lot of time thinking about scaling and operationalization of these models. So I'm curious, at Stanford Health obviously is a huge footprint of its entire network, including primary care practices that extend, not just in the peninsula, but across the East Bay. Has some of this model been scaled across Stanford Health and/or across Medicaid and sort of multiple lines of business?
So the question was about scaling the Stanford coordinated care model, and has it been scaled at Stanford? I have bad news. The answer is not only no, but the answer is that Stanford coordinated care itself doesn't exist in the format that it existed when it started. So it started in 2012 and it lasted like that for about 10 years. And then it was 2021 or 2022 where that model changed actually because patients were not going to because it was too good. Patients were not going to the emergency room. They were not being admitted to the hospital. And when you don't have a closed system, that's costing money somewhere else. And so actually the model has changed within Stanford now, where it's more of an asynchronous model where a patient has a primary care doctor, and then Stanford coordinated care exists as well to support high complexity patients. So I wish I did have better news about scaling this model, when unfortunately my news is that even the original model has been scaled back.
So I'm curious, like what would need to change at the policy or financing level to make that happen?
Yeah, so the question is, what needs to change at a policy or financial level? You tell me. I mean, I think if I had an answer to that, we wouldn't be meeting, and there would be a more scalable model. I would just say first, before talking about the financial model, we have to keep going back to make the case that continuity really is the bread and butter of primary care, and that it really matters that in that model, it was the same 2 doctors and the same 4 care coordinators that knew their patients, and you have to prove that that leads to better outcomes. It led to less ER utilization, it led to less inpatient admissions. If it leads to better outcomes, that is how you make the case that continuity is a good model, because people don't just care about the nice thing to do, they care about outcomes and how that saves money in the long term. Do we have time for one more question, I think from the live audience?
Hi, Joan Duvey. I'm relatively new to California. It took 6 months to get my medical license here, so that's part of the problem. But I'm wondering, I worked in Indiana for a long time at the university and was part of an interprofessional education team where we taught students, healthcare providers, nursing students, physical therapy, occupational therapy, medical students. Pharmacists would come from a nearby school of pharmacy to work together, a team-based approach to patient care. Does that exist here? The Stanford model reminded me a lot of those interprofessional education experiences that I had as one of their faculty. And another question is, while that's great for an area that has a large population base, what do you do in rural communities where you don't have that array of healthcare providers? You're lucky you have a primary care provider, and maybe it's an advanced practice nurse. You always have a pharmacist though. And until we in primary care and in medicine in general stop the infighting, the scope creep conversation where we're always worried about somebody else doing our job, there's room for everyone. I just wondered if you have any comments on that.
So the question was about a true team-based, I think, a team-based approach to primary care coming from another healthcare system, where you have a pharmacist and PAs and you have a whole team taking care of the patient, as well as how that can scale to rural areas. And so that does exist in places like Stanford. I would say it's a scaled back version of the full team that Stanford Coordinated Care provided. For example, within our general primary care, we do have a pharmacist that is part of the team, and they are co-located. I can always just knock on their door and they can do a lot of health management. They do things like manage hypertension and diabetes and can prescribe. They can prescribe Ozempic, which so many of my patients are on right now, thanks to our pharmacists. And so typically I would say it's more of a scaled back version of that team. Like a team would be a medical assistant, a shared medical assistant, a primary care doctor, a shared pharmacist, maybe a dietitian, typically not an RN, typically not physician assistants or nurse practitioners that are part of a pod that then knows that patient. Or if PAs or NPs exist, they have their own separate panel of patients. So it's not kind of that real team-based care where everyone's taking care of the same patients. Co-location is a really important part of it. And I think one of the reasons SCC was so successful was not only did these roles exist, but they all, sorry if this is echoing, but they all just sat around the same table. And so they started out their day by going through a patient list. That was miraculous to me. I mean, so, I work with pharmacists, but everything is going through the EMRs. if they message me, it's adding to a list of maybe 50 to 100 messages that we're all getting, right? Because the EMRs are so convoluted. So we're working through the tech instead of just sitting next to each other and having a conversation about patients. And there's other reasons why we're not co-located. It's actually, there's earthquake laws about why you can't build up, and there's lack of office space at Stanford. It's more complex than that, of course. And then I think the second part of it was about thinking about rural areas where you're not going to get that team. But in rural areas, you will also have fewer patients. You're not going to be dealing with the 2,000 plus, I would say typically you're not going to be dealing with the 2,000 plus patient panel. You might be able to aspire to capping at several hundred patients instead of several thousand patients. And so that frees up the doctor's time to do some of that other stuff, like stuff that dietitians do, stuff that social workers do. I think it's a different question. Do primary care doctors want to be doing the work of the whole team? But, you know, they are trained to do it. And if they had their time freed up from all of this other stuff, like the EMR stuff, the admin stuff, they could be spending time functioning as other critical members of a healthcare team and providing the same level of care. I think that's all I had. Thank you.
And about the mic going there, try to switch over and see if this one's working better. Sorry about the mic glitch there. We're going to switch over. It sounds like this one's working better. Thank you so much, Alana. That was fantastic. So I'm going to move right into our next esteemed speaker this morning. Let me just get this queued up. So our next speaker is going to be Christopher Kohler, who's also, like Alana, a member of our Rev PC expert committee. So as president of the Milbank Memorial Fund for the past 10 years, Mr. Kohler has been leading his organization's significant and influential work on primary care revitalization. That work extends back to his role as the Rhode Island Health Insurance Commissioner, where he oversaw really pioneering and landmark efforts on payment reform and delivery system transformation at a state level as tools to improve primary care delivery. There's a lot more I could say about Chris. I did want to just mention that he did win the Starfield Award. This is an award established in 2012, recognizing Barbara Starfield's enduring commitment to the philosophy that all individuals should receive comprehensive, coordinated, and person-focused care. She's a legendary pediatrician. And it's presented to an individual who demonstrates exceptional work towards advancing the goals of primary care, and that certainly embodies Chris. So today he's going to be talking about some elephants in the room, and please join me in welcoming Dr. Kohler. Where is it? This one's working.
Was that sound check? Okay. Thank you, Tony and Ilana. I'm going to take the baton from Ilana and sort of, I think, really dive into the money piece of this. Won't speak. I'm not a clinician. I won't speak as much to some of the what happens inside the medical center, inside the exam room. But I'm going to speak from our experience and my experience in particular around the money piece, because I think it's really important. Tony gave me the title. I made the presentation fit to it. I kept coming up with more and more elephants as we went through this. You can be the judge as to whether the metaphor works. My comms director will not let me go anywhere without talking about the Milbank Memorial Fund. So this is our pitch. You can now tell her that I've done it. We are an operating foundation as opposed to a grant-making foundation. So I don't have as many friends because I don't, as Sandra does, because I don't give out money. But we spend it on projects. We work mostly at the state level around population health and health equity. There's a reason. We always assumed that population health, if you couldn't improve population health without improving health equity, we've actually had some pretty intense organizational experiences around how that is not the case, as we've owned up to our own history around facilitating structural racism And so as a result of that, for the last few years, we've been very explicit about our commitment to health equity. I got ahead. So what I'm going to talk about is the theory of change for focusing on state and federal, but mostly state. I'm going to quote a federal official who, you've heard Judge Brandeis talk about states are the laboratories of innovation. A disgruntled Fed referred to the states as the abattoirs of innovation. And so you can be the judge of that, but that's really where primary care spending, a lot of the work has been done. Where are we with the state of the state in terms of policy? What have we learned so far around focusing on primary care spending? And then the discussion on, I thought I was going to do like a contrast, but you got into the money. So I'm going to pick up the baton around the money piece and focus on sort of going forward and try to build on the question that Wayne asked as well. I just lost mine. Oh, yeah, can someone save me, please?
Yep, no problem. Yeah.
Hey, Chris.
So let's see. If I can get to here.
I have a very heavy finger, it seems, so whenever I get the touchpad.
Actually, I may need Bill. I'm not sure what happened to our cursor, but we need to go to his presentation. There we go. Scroll down. Keep going.
There we go.
There. Okay, and then the cursor is on the arrow. Yeah.
All right, I get my finger away from the touchpad. Okay. So elephant one. I got actually there are two elephants here. This is the elephant in the room, but what's the sofa? Oh, we're in a university setting, so I want to think conceptually about what the sofa, because there really are there are two elephants that are crowding out things here. All right, I'm not going to grade anybody on this. I think the sofa is two things. The first sofa is the US economy, and the elephant is healthcare spending. So we have 20%, almost 20% of our GDP going to healthcare, way more than any place else. We have to acknowledge healthcare has really become an economic engine. And then with peace to our introductory speakers this morning, the second sofa is not the US economy, but it's the US healthcare system. And the elephant is the amount of spending that we do on institutional care, specialty care, and pharmacy. And it's crowding out primary care spending, which is really why we're all here. So that's the conceptual model. Tony, give me credit. I use the elephant analogy. The theory of change around primary care spending are these four elements. It really is about the Benjamins. We have to focus on the dollars. The primary care is undervalued in the US health system, but assessing the portion of total healthcare spending going to primary care articulates that undervaluing, very importantly, in an easily comprehensible way. For those of you who are primary care advocates, I encourage you to go talk to folks in what I say is the other 80% of the economy and ask them how much of their healthcare dollar goes to primary care. I would do that all the time. I'd have employers say, oh, 20, 25%, something like that. And so it becomes, for those of us who are trying to create momentum, it's a great way to educate other folks. You can set targets for increasing primary care spend. It's supported by evidence and encourages a systemic view, and it also politically organizes folks. We're going to talk about that. And then we're dealing with a market failure here. And so setting targets is a way to acknowledge that market failure. Economists say when there's a market failure, you got to have public policy and you got to political action. So we're going to talk about that too. I hate quoting myself, but this is where we put this out. And the only reason I do it is because if you don't know Drew Collar, you will. He is the next Atul Gawande. I can tell my kids that I wrote with someone who's now published in the New Yorker. This is when Drew was focusing more on clinical stuff. Now he's moved on to bigger and wider media sources, but this lays out the case for why you focus on it. And I'm going to get back to this, not as a way of saving money, but as a way of improving the effectiveness of the delivery system, but a way to assess Any delivery system that you talk about is the portion of dollars that go to primary care. And I'll say here, we are avoiding the hard questions that a number of people have asked about what is the right level, what should the money actually go to. Those are all important questions, but they're second order questions. Until we get until we don't know what the right level is, but we know it's more than where we are right now. So let's focus on that and not get tied up in important but more detailed questions. And contrast the systemic approach when measuring primary care spend with payer or payer type specific. Those are all good, but frankly, they're not systemic enough. We are not going to innovate our way to a stronger primary care oriented delivery system. I'm going to take up Wayne Altman's challenge around should we take primary care out of the funding scheme. Where are we right now in terms of the evidence from primary care spending? And I use the term primary care spending, not primary care investment. I'm giving away some of my punchlines, but I think those of us who work on primary care should avoid the term primary care investment. It creates an expectation of a return on that investment in the short term. That is why in the NACIM report, we talked about primary care as a common good, because if you use the language of investment, folks are going to say, okay, where's the return? And the return's got to be in savings. And as my colleague and primary care advocate, Asaf Baton says, we do not ask pharmaceutical companies what the return on investment is for their latest innovation. We do not ask imaging companies what the return on investment is. It's an improvement. And we should use that same language here. So the state of the state, there's evidence that countries with relatively high primary care spend rates do better, however you want to define it. Tony gave some of those, some of that evidence at the start. It's very hard to compare between countries because of different definitions. We've tried that. We tried to do it in the NACIM report. It was hard. There's no particular evidence for state because there is variation in primary care spending levels within states. There's good but not systematic evidence that high-performing integrated delivery systems have higher primary care spend rates. Tony cited the evidence from California. There's also evidence in Massachusetts. You've seen that Medicare Advantage companies, the primary care only plays, are investing heavily in primary care. Rashika Fernandopoulos, when we've appeared together, just routinely says, oh yeah, he was the head of IOR before they got bought out. And he says, oh yeah, 13%. That's what it is in my delivery system. So they get it. And we've got now data coming from CMMI and CMS, sorry for all the acronyms, about the performance of Medicare share savings programs and that physician-oriented accountable care organizations do better there. So we put forth this idea of primary care spending in Rhode Island. I'll talk on the next slide about the specifics of that. And I've been very gratified, or we've been very gratified by the take-up of it. And that's part of why we're talking here. The number of states that have jumped on board with some form of public policy measure. And with help from the California Healthcare Foundation, we produced this state map, or we developed the state map for this presentation. I want to differentiate between how different states are doing. And our focus here is public policy, because we think from a systemic approach, you've got to pay attention to the public levers because we're dealing with a market failure here. Some states are saying we're only going to measure once and let's see what happens. Some states are saying we're going to measure regularly, we're going to set targets. And then the blue states are states that measure and have some sort of a mandate to increase. And I'll talk a little bit about Rhode Island in particular, because that's the place where I have the most experience. We did it focusing on commercial insurance and fully insured commercial insurance. And we could do an increase, we can mandate an increase because of Rhode Island has comprehensive rate review for commercial health insurance. So we could say, health plans, if you want your rates, you have to increase your primary care spend, and you have to do it within the constraints of the premiums that we have approved. So it's a very explicit rebalancing, more here, less here. We're taking the role of the heavy so that when the health plans go to the purveyors of the dreaded laminated fee schedule, I've been there in managed care when you sort of show up in front of a monopoly provider and you've got the market and you got to have them, and they hand you their fee schedule. We're giving the health plans a response to that, to say, no, I can't give you 5% increase. You're going to have to live with 3% because I got to put more money in primary care. Very few other states have this sort of comprehensive rate review. It is a partial solution. In Rhode Island, to be clear, it doesn't carry self-insured. It has no effect on Medicaid, so that you still need to coordinate across payers. But the platform that we had to stand on in Rhode Island was commercial health insurance. In other states, like California, you might have stronger levers around Medicaid, around the benefits exchange, places like that. And so Rhode Island's been doing it for a few years, since 2009. And a lot of what I'm going to say or refer to sort of reflect on what the experience has been will be really on the blue states in particular and the calls to measure an increase. Oregon was the first to follow. Delaware came on, and you see the other states there in blue as well. So that's a little bit of background around primary care spending and the variety of sticks, if you will, or sort of enforcement mechanisms for making it happen. But to be clear, this is a partial solution. In Rhode Island and any place else, commercial health insurance in Rhode Island is about 30% of the market, maybe. And so for a typical physician's panel, clinician's panel, that only means you're getting this quote windfall for only 30%. So this discussion that we've been having about the need to coordinate across payers is really important. So what have we learned and what's happening? One, we haven't succeeded with these primary care spend laws. This is data from Milbank's scorecard that Alana was nice enough to refer to. And I want to make sure I got this right. Okay, I skipped over the lessons. So I want to make sure. Oh yeah, all right. Sorry, I missed a few slides. I'm still touchpad. The feds are following suit. We got mentions around primary care spend, that measure in the Implementing High Quality Primary Care report. Deb Cohen and her colleagues have taken up the challenge of actually defining what primary care is and trying to, we've had a problem with we have 1,000 flowers blooming, different states are using different definitions. We have to standardize on it. My philosophy has been not to wait to get standardized on that, but create more demand for it by having more states trying to do it. And then the feds can jump in and actually come up with a standardized definition. And then we're very pleased to see the mention in the CMMI ahead model with this very explicit effort to rebalance focusing on primary care spend. I do think there's an opportunity, and I've been talking about this here at this meeting, to further socialize primary care spending measure within CMMI payment model evaluations. That's a very systematic innovation that's going on. I love to see it referred to regularly in terms of ACO. What was the effort in CPC Plus and MSSP, any of the new stuff. I think there are real opportunities just, again, for organizing to get people focused on what an important measure that is for a balanced delivery system. And we've been working on it in CMMI. An implicit goal of all the CMMI payment models has been this rebalancing. So let's measure it and understand what's going on. So what are the lessons so far? And I apologize for skipping ahead. Primary care continues to weaken. It is the primary care spend measure is a powerful organizing tool, at least for those of us, quote, in the know who care about it. There's still technical questions. And there's no clear evidence yet that it has made a specific difference in terms of producing a more primary, whatever you think your definition of better is. Happier clinicians, happier patients, a more balanced delivery system. And I'm going to talk about each of these. So primary care continues to weaken. Alana and Tony were nice enough to refer to the scorecard. This is what our primary care spend measure has done. Part of the problem here is we don't have a perfect measure. So this uses you can go down the rat hole of how do you measure this stuff and we'll have a whole, please let's not have a whole measurement discussion, but you can. And we use MEPS. It is in medical expenditure panel survey. It is imperfect. because it is a survey of clinicians and where their expenses go. It doesn't use claims. Some states are able to use their claims measures. Some states are using what the health plans, the payers submit to them. We think it's more important to be consistent than accurate. And so we've been consistent over time, and you can see we're not making particular progress. It's flat. So all of our, state level innovation, it ain't showing yet. We talked about the decline in primary care physicians. Hats off to the Graham Center and the work that they do. They really are leading around a lot of the workforce measures. So this is what's in the scorecard. By the way, where it's available, we've got state level data in our dashboard, so you can go and get state level data until you organize your own state level scorecards, which several states are doing. I think this is really important for those of us who care about primary care, because this is how we start to engage consumers and sort of equate what is sort of a wonky, detailed concept of spending in dollars to something that they feel. The percentage of people who report not having a usual source of care is steadily increasing. It is not skyrocketing, but it is increasing. And the really important thing is that this happened at a time when we were quite successful at expanding insurance access. So it is incontrovertible that people with access to a usual source of care, however they define it, do better. There's mounds of evidence around that, and we are failing at that in the US. And I think this is something that the public can relate to, because this gets at, so what Alana was talking about, it gets at issues of trust. If I don't have a usual source of care, I'm just not going to trust the system. And so I would encourage those of us who are sort of thinking about this to focus on this measure, because I think it translates well, even better than the spend measure. Thanks to the Graham Center, we've got projections around physician supply. This is a reproduction of a slide I did in Nebraska, so that's what all the NE refers to, but you can look at the dotted lines. And what they've got, the blue is primary care physicians, and we're speaking here only about physicians who are going in. You see that flat blue line, dotted line. The physicians who are leaving, that's the increasing green line, dotted line, and then the net is the black line at the bottom. So we're in trouble. And advanced practitioners are not going to save us, because they are subject to the same economic incentives as clinicians, as Bob Phillips was educating me. So the future is not looking good. What is looking good is that this is starting to hit home. It's not becoming just a wonky conversation. People are starting to, this lack of access, however you define it, wait time, my clinician left, it's starting to get to the public consciousness. And that's why we do the scorecard. And, to give away my punchline, I think we're not going to have a series of technical fixes, including primary care spend, to address this. We have to get the public interested in it. And I think we're starting to get to that point with the access, because it's becoming a middle class issue. Access is, I think, relatively better for Medicaid populations, because there are no barriers in terms of cost sharing. CMCS is doing more access regs, but it's becoming a middle class problem. And that's what politicians pay attention to. Lesson 2 is that it's a pretty powerful organizing tool. So we're seeing activity at the state level. And when I'm calling out our state scorecards that have been developed in Massachusetts, a couple slides on what they're doing. We also have one in Virginia. So groups, they are not often the public sector, their private sector partners are taking up the task of producing relevant state level scorecards. Some people can be concerned that different states are measuring different things. They're measuring primary care spend in different ways. I don't really care. So long as there's political movement around it and they're able to compare their trends over time. Virginia's been really crafty in that they do this stuff by Senate and Assembly district, so they can create some local interest among the policymakers. I think that's really clever. Perhaps there's guidance for California and other states as they think about this stuff. And also, the creation of the scorecard creates a organizing movement outside of state government. We cannot rely on our partners in state government to carry this alone by themselves. They need folks on the outside who are making primary care a priority. They need partners so that They have colleagues that they can work with, and frankly, they get besieged by the folks with the money, the academic medical centers and pharma, when they're trying to do this rebalancing. So developing, I think that's one of the key lessons, is developing you cannot rely on the public sector to deliver this. Public sector response to political pressure. Primary care has to figure out how to do political organizing to give cover for public sector to do what they know to be the right things. Technical issues remain. We are sooner or later going to have a standardized definition. It's got to come from the feds. Hopefully, the state level activity will create increased demand for that, and I'm looking at Deb. We'll take your paper, Deb, and it will, from your lips to CMS's ears. We have to define the denominator in terms of what constitutes total healthcare spending. You'd think that'd be easy to measure, but it's not. As well as if you think of the first one, that's the numerator. There remain questions about data sources and what are definitive data sources. Do you do claims? We have a real problem with non-claim spend, and how do we capture that from different places? And then there's continued pressure to expand the interest beyond primary care, to talk about behavioral health and public health in particular. That's okay. I mean, I think they're sort of they would help with the vision that Alana is putting forth. But we do have to be, I think, like any political movement, it's kind of messy, and so you have to work through these definitional issues. The second or the third elephant in the room, however, is the fourth thing that we've learned, which is that the evidence around increasing primary care spend, it makes logic in the world, all the logic in the world, but we cannot show that those states that have mandated it, Oregon, Rhode Island, that you have whatever your definition of success is. Again, happier clinicians, better population health, more health equity, certainly not lower cost. And I think we as advocates and folks interested in primary care spend have to address that fact. The states with policies in place mandating spend, those are the blue states in that map that I had. They have a problem defining what is stronger primary care. If you walked into a primary care clinician in Rhode Island, they wouldn't understand why people are so interested in Rhode Island. They're experiencing all the pressures that Alana talked about, the miserable charts, the miserable appointment scheduling. They're not driving better cars. They're not shutting down at 5 p.m. and going home to their kids. And so we as folks interested in primary care spend have to face up to that. And I'm going to talk about sort of where we go from here. Russ and his colleagues at Harvard are sort of trying to learn in a more systematic way from the experiences in Massachusetts. And we got to learn from this. Let's see, the observed challenges with trying to increase primary care spend. We've got a real problem with reliable measurement as California thinks about that. Be sure you staff the measurement process because people take their eyes off the ball. We've got to think about where the categories of primary care spend are. This question, not all primary care spend is equal. And if I had to do it over again in Rhode Island, I think we'd be a little bit more directive about it. This question of accountability ensures it's a pass-through. So should we be focusing more on delivery systems? What are the enforcement mechanisms? Targets generally are not enough. This issue of aligning across payer types. People pay attention to Rhode Island and Oregon, but they've only got the commercial piece. Oregon's got more. So how do you get that? And ERISA is the big gorilla. What do we do with employed clinicians? Shoot. I can show you that money is going to UC Davis. Can I show you that it's getting through to primary care clinicians? And do we want to put in regulatory apparatus to try to maintain that? It's an important policy question. And Alana talked about, and we've talked about hybrid payments, and we're doing this all in a fee-for-service system. Is that the hamster wheel? NACE's been very clear we want to do hybrid payments. How do you use primary care spend regulations to encourage that? I think the big issue is how do you get engaged stakeholders? This cannot be an inside battle. It cannot be something with clinicians only. So the ways forward, I've been given the hook, so I'm going to move quickly through this. 4 things I think we who are working on this have to do. The first is to remember the why. Avoid promises of savings. We're not doing primary care spend. We're not talking about rebalancing to save money in the short term. My experience is employers understand that. They don't want to see all their money go to specialty care. So they will be actually sympathetic as long as it is posited as a rebalancing, not as an increased cost that they have to pay, even though it's pennies on the dollar for primary care. The second piece is we have to continue to measure. I think that's how we socialize this. Again, I'm an advocate for not letting the perfect be the enemy of the good. Let's just get the measures out there. It should be I would encourage any public sector official, Medicaid, benefits exchange, CMMI, to make this a regular evaluation measure that you are using for your health plans, for your delivery systems, wherever you're trying to do payment reform. Think of this the way we think now about HEDIS or public health measures. We have to learn and improve. It's really interesting. Rhode Island just released new regulations. I think they kind of took their eye off the ball for a while. So when Rhode Island does new regulations around primary care spend, it's a series of technical changes. They changed the numerator, how they define primary care. They changed the denominator. So you're going to actually see Rhode Island's primary care spend number go down because of some specific changes that they made. And then there's some other areas that you can think about when you do this stuff. Last, I think we have to think about the whole strategy of just pushing more money into primary care. I use this analogy of, are you going to pour more water into a desert? If the system is not set up for this, I think the analogy I came up with, I had to do this presentation again, it would be about pushing the string. We have to think about pull strategies as well as push strategies. And this is where I get to the question that Wayne asked last time. Are we better off taking primary care out of the rest of medical spend? Or are we talking about redesigning the economic incentives? And Wayne, for the sake of argument, I'll make the case that we don't want to do for primary care what we've done for public health. Separate it, it becomes politically weak, and it's perpetually underfunded, while the places with political and economic power continue to control the allocation of resources. So the alternative, I'd say, is you have to acknowledge that if you're working on the delivery system, on the foundation, you got to pay attention to the building as well. This is again a little bit shameless self-promotion. This is an article that Elliot Fisher at Dartmouth, Carrie Colley, myself, and Elena Berube put out about what state level. This is a public sector strategy. This is saying that the market doesn't work. We're not going to innovate our way to the future. If not only primary care, but healthcare is a public good, we have to use public forces to reallocate. And it points to 4 specific areas. I'll just read them out. Oversight of spending and growth targets. Elizabeth, you'll feel like this is like the California roadmap. Global budgets for hospitals. All payer accountable care organizations with downside risk. It is the only way this is going to work is if the places like UC Davis are at downside risk, so primary care can rise to its correct level. And I would rather have a system that is self-perpetuating like that than one that's a regulatory one where UC Davis has to document to the public sector folks some sort of complex accounting measure how the money is making its way out to primary care clinicians. Downside risk, it's easy to say, it's hard to do, but I think that's if we don't want to have a public sector system that's reallocating, you have to align the incentives of the delivery system. And then you have to deal with monopoly power and the underlying pricing that gets at it, because the market power is real. Economists are right. They may be dull, but they're right. When you have economic and political power, you're going to use it. This is my last slide. I saved, I think, the hardest bullet for the last, which is how do we get, if we're looking for public sector solutions, this is public policy, this happens with political pressure. We still have 80% of the economy that is not healthcare. And how do we get them energized, not only around the future of primary care, but around the idea that spending 20% of our economy on healthcare is not good. It's not good for population health. It's not good for health equity. It's not good for economic opportunity. That's a really tough sled. And maybe we've got to start with campaign finance reform so that we reduce the power of some of those voices. But we're not going to innovate our way out of this. And technology is important. It will help a lot, but I don't think AI is going to address the problems that Alana put out. It's not going to, by itself, create systems of care that patients can trust. And that's really what we're trying to do here. We think primary care is the way to do it. And I think you got to pay attention to public policy as you work on this. So again, I think the last bullet is where our work is. It's hardest. I'm guilty of waving a magic wand and saying it will just happen, but that's where we have to be working on this stuff. So I'll stop and take any questions. Thanks.
Thanks very much, Chris, and we're glad that moving forward, you'll get to make California blue as of this week. So you talked about not for all primary care.
Blue in terms of my chart. This is not a paid political advertisement.
Not political, right, correct, although, you know, that also fits. But blue in terms of having a primary care benchmark. So you talked about not all primary care being the same and that there's, you know, higher value primary care and that you wish maybe you had made some changes in Rhode Island looking back. Can you talk a little bit more about what you would have done differently or what you think we should be thinking about in California?
Yeah, you've got to find a Goldilocks approach. You can't just say, all right, any code, any payment for any code to any specialty works. But you don't want to overregulate because then the health plans come and they get into this mother may I kind of thing. I would focus on hybrid payments and I would focus on actually wherever possible align with Medicare, because I think there's some good ideas coming out of Medicare and I think alignment is really important. So, you know, it's a great question, Elizabeth. I think I would say, where are the feds going and how can I get my state regulations closest to that so that I got consistent economic signals that the providers are getting. The big opportunity now is the advanced primary care management codes. I would be beating the heck out of those to make sure that there is as much take up as possible. I would be pushing my Medicaid plans and my benefit exchange plans to pay the same way because you want alignment is just so important. You know, you gotta get to 60 to 70% of payment aligned, people say, before the practitioners do it. So that's where I would go. I wouldn't do it by myself. I wouldn't come up with something by myself. That's sort of our definition of perfect. I'd say, where are the breadcrumbs going and how can I add to that?
We have a Zoom question.
Okay.
This is an anonymous attendee, but they asked, are there conversations with Oregon to see if some of their policies for reimbursement could be applied to California?
Are there conversations going on with folks in Oregon to see if some of the policies around primary care spend can be repeated here in California? I see Elizabeth nodding yes. And Elizabeth, you want to add to that? Because I can't speak to California. Or Margareta?
We're definitely talking to Oregon.
Affirmation.
I think I'll just note that states with both spending growth targets and with primary care investment targets do lots of coordination across those states.
Yes. Another thing we're pushing hard.
Your presentation, Sam from California Healthcare Foundation. So you said not all primary care spend is equal. If you were going to take our primary care spend to 15%, which we have an aim to do in California, and we're trying to address equity and quality and population health, where would those dollars go in primary care?
I really don't want to answer that question, Sandra. What it was like, how do we create incentives for the academic medical centers and people with economic power to do this kind of work? In some ways, I think that's a foundational piece. But from a health equity standpoint, I think this is a little bit wonky, but the feds are coming out with access regulations for Medicaid. And because you're focusing on health equity, the people who experience the greatest disparities tend to be people who are enrolled in Medicaid. So I would be understanding those regs as they're coming from CMCS to the state and shining as bright a light on them as possible. And then asking that question in light of those regulations. So where can Medi-Cal spend its primary care money to most satisfy the standards that they're being held to by CMCS? Same principle as what I said with Elizabeth. What are the pressures that people are under and how do I align with that? Now, I don't know those access regs particularly well, but I know that Medi-Cal is going to be asked, okay, how are you complying with it? And I would think understanding what they're being held accountable to, and then making sure that they're written into the managed care contracts, and then trying to spread them to the benefits exchange. So again, you get that kind of alignment. I'm not completely answering your question, because I'm not gonna pick health centers over special, over uninsured clinics or something like that, but I pay attention to the environment that the payers, both Medicaid and their subcontractors, the MCOs, are operating under. The feds are really serious about access and about equity. So how can we increase the pressure to align the payment? I do think alignment's really important.
So I just want to speak to the California Oregon issue a little bit. Because
Deb, do you want to introduce yourself?
I'm at Oregon Health and Science University. I did our technical brief and have had multiple vantage points for looking at this. And I'm truly grateful to Chris, who's been a leader in this area, in Mildred, who's done a lot of work in this area that I think created the opportunity for that brief. But there has been learning, I think, since Oregon and Rhode Island started this work. And I have to say, there's a part of me that's both proud and jealous of Rhode Island, who's redone their measurement, because I think probably the state has learned as other states have come online. But when you read through all of Oregon's spending reports, and states that do spending estimates every year publish a report every year. In 2018, they changed their estimate. But the implications of these very technical changes are hard to understand.
Yes.
But when you start talking to people in Oregon, what you immediately learn is that one large health system made some changes that included a lot of nurse practitioners and PAs in their estimate that don't actually deliver primary care. And they excluded some pharmaceutical drugs from the denominator that took the state to 12% target within a year. So there actually hasn't been an increased investment truly in primary care, because Oregon entities found a way to avoid that. So getting back to the anonymous person's question, I actually think we're in an interesting spot now where Oregon has some really important things to learn from California. So I'm glad that dialogue is happening, because as new states have had the advantage of the prior states, they're innovating and bringing together partners and redefining this definition in ways that are really important for the earlier states, I think, to start learning from too. It's an iterative process and it's super technical. I have learned that you cannot speak about this with people at a party, their face just and they walk away from you. So
Thank you, Deb. And I just for the sake of imagination, imagine if we could take that large academic medical center that probably ends in U, but we're not going to name names. Oh, really? Okay. And get them on some sort of population-based payment, because then we could, primary care would find its own level, and you would start to align incentives, as opposed to this cat and mouse game where we're oh, you did that, okay, we're gonna forestall that, and then you're gonna find something. As a recovering regulator, we had to deal with that all the time. People are always finding ways around it. You gotta align the incentives.
Thank you, Catherine Phillips from the California Healthcare Foundation. And I want to put out another elephant in the room, which is the lack of alignment and accountability between our state and our nation's educational institutions and the needs of our delivery system. So we heard earlier from Alanya about an incredible care model in clinic at Stanford Medicine. Stanford Medical School failed to graduate a single student who selected primary care on match day. They did get a couple psychiatrists, which we are celebrating, but zero pediatricians, zero family medicine physicians. So as you think about public policy opportunities that are financial in nature, sort of the Benjamins as you called them, what can we as a state and a country do to better align our educational institution with the needs of our delivery system?
So you're sitting next to Bob Phillips. Unfortunately, Bob has whispered in my ear a fair amount. Graduate medical education. It is around understanding, not understanding, increased accountability for the graduate medical education payments that we pay. We physicians and clinicians don't just automatically, you guys know this, don't automatically become expert. They have to be trained. And we pay for that training. We pay for it with Medicaid and Medicare, and we don't know what we get for it. And those of us who were at the dinner last night heard Bob talk about this. So I think there's enormous work to be done, both at the federal level for Medicare and the state level for Medicaid around accountability. I'm limited on this, but particularly at the residency level. So it's fine to beat on Stanford Medical School. It actually, I think to change Stanford Medical School, the most effective way is to change Medicare payments so that we have to address Medicare spend. But in terms of the residency programs themselves, the next step, they're getting money from Medicaid and Medicare. We don't know what we're getting for it. So I think there has to be way more transparency around that kind of work. I hope that's helpful. I got assigned for one last question. So you've got the microphone, so you have control.
So UC Davis, I believe, we're at the 99th percentile and percent of our graduates going into primary care, which is great. However, at the end of the day, it comes down to money. So we're seeing a little bit of a drop. And on our last graduation questionnaire, the students responded that many of them are choosing their specialty based on their compensation.
Yeah.
And we talk about letting federal agencies be the drivers of some of this, but Medicare and Medi-Cal pay below the cost of delivering care. And we are seeing financial pressures in our organization as more and more practices close to Medicare. I was under the impression Stanford didn't take federal payers, but so how do you see this all working? I mean, we're doing God's work of inspiring people to go into primary care, but even that is eroding because of the reimbursement pressures. And those who are responsible for policy aren't paying enough for primary care for people to make a living.
So thank you. I'm going to dodge around the question of costs because what is adequate payment? Adequate is in the eye of the beholder. There's clear that Medicare underpays primary care relative to other places. That's why NASM, the first thing that they did was to get Medicare payment rates raised. I can't speak to Medi-Cal. I know there's a long and tortured history around Medi-Cal payment rates. I don't know how that works out in terms of managed care organizations. I think the first step is always transparency. If you believe, so from your standpoint, if you're giving your commitment to primary care, educating people about what you get from Medi-Cal, what you get from Medicare, what you get from commercial. The other 80% that I was talking about, the populace, they have no understanding of this rate variation. So you have to, and I find my own experience that people do understand rate variation. So when we started to work on primary care and hospital payment, the first thing we did was compare everybody to Medicare, Medicaid, the individual health plans to Medicare, just as a reference to at least say, do you understand the variation that happens here? And then it's about this is public policy process. So it's how do you make the case for increased Medi-Cal funding to go specifically to primary care and not to all the other places. I mean, the budget's limited, so we've got to place primary care ahead of some other priorities that Medi-Cal has, and that's not going to, or the legislature has, that's not going to be particularly easy. The one thing primary care is going for it is that when you're only 5%, if you move it to 6%, you've increased their reimbursement 20%. There's an enormous lever effect there, which with relatively small on the overall budget. But it's the folks that this is a political process, and we've got to influence the public policy. Is that? I'm looking for Tony.
I think we're good.
Okay, thank you very much.
I hate to end the discussion. That was fantastic, but we do have a poster session now and a little break for refreshments. So remind me, Doug, what's the timing when we'll reassemble for our expert committee?
11:15 for the expert committees, but we're going to divide up into our breakout groups.
Great. So we'll bring some bells and do things to sort of bring the expert committee back in. Is that correct? Yeah.
Posters are throughout. Please mingle everywhere and check them out. Thank you.
Okay. Thank you.
have that.
We're supposed to put up the instructions for the next place for them